Okay, so now we've done everything we can non-surgical to help control the symptoms of pain. We've tried the bracing, we tried the weight loss, the exercise, the medications, and we tried injections. So now we're talking, so we've gotten to the point you're still hurting, so now we got to begin the discussion of surgery. What can we do surgically to help patients who have knee arthritis? And it goes, again, as always, we always go from conservative to more aggressive, but everything from a knee scope, you guys heard of knee scopes, all the way to doing a knee replacement surgery. So there's kind of three options from a surgical perspective we'll talk about real quickly. The first surgery we talk about is called, the knee scope. Has anyone had their knee scoped in here? Okay, 3 or 4 or 5. Okay, so not uncommon that patients will try a knee scope to help clean up some of the stuff that's in that knee to give you some relief from the pain. Okay, and so what we can do by doing a knee scope is, if you got little loose pieces of cartilage floating around your knee, we can pull those out. You got loose flaps of that white shiny stuff, we can smooth those out. You got any tears of the cartilage, we can smooth that out. But I put this statement here, indications are narrowing. What does that mean? To scope a knee that has significant arthritis I compare it to baseball. We're not going to hit a home run by doing that surgery. Our hope is to get a double or a triple. What do I mean? We're trying to give you a little bit of relief, but we're not going to knock out all your pain, okay? A scope is to kind of clean out some of the loose stuff, but you still have arthritis after a knee scope, okay? You're just getting rid of some loose flaps of cartilage or loose flaps of the white shiny stuff. So the next word here is osteotomy, all right? Osteo is bone, otomy is cut. So cutting the bone sounds pretty major. Well, it is. So I talked to you a little bit about how a brace, we can put you in a knee brace and unload the knee joint where you have the bone grinding on bone. We can jack it open. Well, we can also do this surgically, okay? And I'll show you what I mean by that. All right, so here you see a picture of a knee with bone touching bone here on the inside, okay? So we could try a brace that would jack this knee open and open up this space, okay? So you try a brace, or you try those little heel wedges I was telling you about. Stick a little heel wedge in your shoe, see if that gives them relief. If not, and you just have that one area of bone grinding on bone, you can cut a little piece of pie of the bone out and realign the leg, and let me show you what I'm talking about. So you take a saw, all right, this is in the operating room, and you cut a wedge of bone out. I'm gonna throw that in the trash. And put plates and screws in there and realign the leg and start jacking open that space, okay? So you can see here, this left picture, you got bone touching bone. Here, you're starting to see how this space is getting jacked open. This is a big deal, okay? We do this in patients, the younger patients in their 40s or so who want to stay very active. We'll do what's called a high tibial osteotomy. This is a tibia bone. Osteotomy is cutting the bone. They have to have no arthritis anywhere else in the knee except for one area, okay? Because if they had arthritis over here and I jack their knee open, it's going to put more pressure on here and it cause pain out there. So they can only have arthritis in that one area, okay? So high tibial osteotomy, big surgery. You can't put weight on your knee. You're on crutches for about 6 to 8 weeks, maybe even 12 weeks. So very limited use, but it is an option we have. All right, last but not least, this is arthroplasty or knee replacement surgery. So we've tried everything, okay? Nothing's worked. You got bone on bone everywhere in your knee. Medications hadn't worked, braces hadn't worked, exercise hadn't worked. So we're ready to talk about total knee replacement, okay? I'm a knee specialist. I do a lot of these. So joint replacement is a little bit of a misnomer, I think. The better way to talk about it is it's a joint resurfacing. So we're getting rid of all the white shiny stuff and replacing it with white silver stuff, metal, okay? And then putting plastic where the meniscus were, okay? And then the knee moves. But you have no bone grinding on bone. You have metal rubbing on plastic. So joint replacement surgery, one of the best surgical procedures ever created. Well, what do I mean by that? When you're talking about patient outcomes, and so you have patients who fill out of evals after they've had knee replacement surgery, it's one of the top 2 most successful surgical procedures. 95% good and excellent results, hip and knee replacements. And that is coming from a patient's perspective that they would have it done again or have the other knee done or other hip done, okay? It gets rid of the arthritis, it solves the problem, but it's still big major surgery, okay? So probably about $500,000 done each year, okay? It's road tested. We have very good data. Knee replacements were started in the 70s by Dr. John Insall in New York. That's where I did my fellowship. So I trained with the guy who sort of created knee replacement surgery. So we have tons of research on it. 95% good or excellent results from a patient perspective, okay? We have knee replacements that have lasted 20 plus years, okay? And the other thing, it's an elective surgery, okay? And of all the options that we've talked about for severe arthritis, the knee replacement is the most predictable results. So if I tell a patient we're going to do a knee scope and we're going for a double or a triple because you got bad arthritis, I tell them we would hit a home run with knee replacement. We're going to get rid of everything, your pain will be gone, okay? This is barring any complications or other things. So it's the most predictable result when it comes to relieving the pain, restoring motion, and kind of getting you back to kind of doing the things you want to do, you know? So you may have heard the term mini incision, smaller incision, less invasive surgery. What does that mean? Well, so let's look at, this is a patient of mine, okay? This was her knee replacement on her other knee that was done probably about 15 years ago, okay? Because 15 years ago, that's the instrumentation that we had. We had to make big incisions, you know. So here's the one I did on her. She came and saw me. This was probably about 3 years ago. And you can see the incision. I'm not sure how well you guys can see it, but you know, the incision goes from about here to here as opposed to from here to here on this knee. What does that mean? I mean, incision length is not that big a deal, okay, to the surgeon. To the patients, they kind of like, oh, look how small my incision is. The most important part is making sure you can do the surgery correctly. If you can't see what you're doing, you can't do the surgery correctly. So the most important thing to do is for the surgeon to see what he or she is doing to do the surgery correctly. It's because of the newer instrumentation and the newer technology that we're able to do the surgery now through smaller incisions, which are speed up recovery, decrease pain, and decrease blood loss. Okay, so here, so I outlined those incisions here. Let's see if you guys can. So that was the old incision. This is the one we were able to do on her other knee. Not for the simple reason technology is better. Okay, so this was a knee replacement done probably about 25 years ago. Okay, this is the foot. This is the knee. That's the metal here, and the knee is bent like this. Okay, that incision on this patient is going from here to about right here. Okay, we don't do that anymore. So my point is, joint replacements are evolving, and we've gotten it down pretty well with a small incision, quicker recovery, and great outcomes. Okay, so you can see the little metal there. That's the kneecap sitting right there on top. Kind of gross, isn't it? So now here's the mini incision. So here's what we can do now. There's the kneecap. That's the knee, little tiny incision. So we can do it all now through these real small incisions. That's the final product there. Metal, plastic, metal. It's connected to the bone with cement. New technology, there's different, you know, traditionally the implant's made out of cobalt, chrome, and titanium. There's newer metals, acrylic metals, ceramics, metal on metal, zirconium, trabecular metal. So this may be what she has in her knee, what's called a trabecular metal implant, where this plastic is already attached to the metal on the bottom. And so you have to take the whole thing out to replace the whole thing. So, but the good news is, the pores in this metal match the pores in your bone, so the bone can grow into it. So I use this occasionally on certain patients. So new technology, I'm just kind of going through these pretty quick. You can do partial hip replacements here. So you don't replace the whole stem, just partial. You can do partial knee replacements. You just replace the part of the knee that's got bad arthritis. Okay. Computer-assisted surgery. Now we got the technology that we can determine where we need to place the implant based on computers that are brought in the OR, and we check alignments and measurements, and so, you know, called CAS, computer-assisted surgery. And I don't think I have a slide on the most recent technology. This is just more pictures of all the instrumentation, these electrodes that attach to the leg, and it tells you where you are in space, and make sure we get the prosthesis put in, or the knee replacement put in where it belongs. Female implants. Okay, so there's gender-specific implants that are being marketed. Zimmer's the one who markets it heavily, and I will tell you that a lot of it is marketing. The results show no difference right now. So short-term results. The female knee has been out for about 5 years. The 5-year data says there's no difference between that and a traditional implant. There are some good uses for it, so I do use it, but I sometimes will use the female knee in a male because it depends more on anatomy rather than the sex. So you got to look at their knee and the shape of their knee and certain things on their knee. So I've used a female knee on a male. Okay, I think a lot of it's marketing, but the bottom line is they're very good results regardless. Let's see here. Okay, good, I did get this. So patient-specific instrumentation. This is the newest technology we have. I started doing this in January. The surgery's still the same, but what we do is we get X-ray, a specialized X-ray, a specialized MRI, and the company custom makes the instrumentation for your knee. And when the surgery's done, they're thrown away because it's for your knee and only your knee, okay? So what does it do? It's less blood loss, less pain. It matches your anatomy perfectly, okay? So again, I've been doing them since January. The surgery's still the same, or the result's still the same. How I get there is a little bit differently. So, but the patients have done great, okay? So it's these plastic disposable implants or instruments that allow me to make the appropriate cuts on the bone to get the prosthesis in there. So that's the newest technology we have now is patient-specific instrumentation.